Welcome back, everybody. We're going to get started with our final presentation of today. And just a reminder, I mentioned this earlier in the day, we will be linking our conference evaluation for today's sessions in the chat. And so everybody should be able to access that once that is shared. We will also be sending it out. So you can access it there as well, but we wanted to make it available to you in case it's easy just to go ahead and share back your feedback. It's very fast. We don't ask a lot of questions, just want to get a quick sense of feedback for your, from our attendees for today's sessions. And we really value that. We look at them every year. We look at them and informs how we do this conference in future years, and especially even content and things that we might want to try to address in other ways throughout the year, even ahead of next year's conference. All right, so with that, I will introduce our final session, and specifically, I'm going to introduce Adam Van Spinkeren, who is the session facilitator and moderator. So Adam Van Spinkeren serves as the Navigator Program Manager for Covering Wisconsin. In this role, he oversees and supports a statewide team of health insurance navigators who help individuals and families understand and enroll in Medicaid and Marketplace health insurance and related resources. With 20 years of experience working with public benefits and health insurance programs, Adam plays a key role in improving access to health coverage across Wisconsin. And I think a good number of those 20 years, and I don't have the precise number in front of me, were spent right here in Covering Wisconsin. So I'm very pleased to hand it over to you, Adam.
Great, thanks, Allison. We can give you a break now. Allison has been doing a really fantastic job, but I think she deserves a short rest at least. So thank you all for your participation this morning. Really great questions came in during those sessions. We talked a little bit about both Medicaid and Marketplace and new policy. We talked a lot about Marketplace, and now we're going to pivot back and talk a lot about Medicaid and take a closer look at Medicaid programs, specifically the ones that we get the most questions about throughout the year. That seems to never change. We have two great speakers with us. I'm going to introduce them in reverse order so I can hand it off to Masiel when I'm done. Masiel Grochocinski is the Program Manager and Policy Analyst at the Wisconsin Department of Health Services. She serves as the State Health Insurance Assistance Program, or SHIP Director, an Elder Benefits Specialist Program Manager, and an Older Americans Act Legal Assistance Developer. She has a master's degree in social services administration with a concentration in older adults from the University of Chicago. And I will say Masiel is my favorite new partner that I've worked with, I would say, in the last year. So she's very knowledgeable, and I have appreciated working with her these past few months. So very excited to have her. Masiel Gomez, you should know. If you don't, if you do this work, you should. She's also been one person who has been throughout the chat and the Q&A. She often says she'll take things back. She's an enrollment and outreach coordinator. She works directly with organizations like ours and all the other organizations that assist clients and consumers in enrolling and maintaining their benefits. She provides key leadership and support to a number of different groups. All the policy and partner updates and clarifications we get, a lot of them come from Masiel. She has even more experience than I do working with Wisconsin Medicaid, so over 21 years, and is always using her skill and expertise to help people solving policy questions, eligibility questions, all of that. So I want to say thank you, Masiel. It's always a pleasure to have you and work with you, and I will turn it over to you.
Well, that's just such a wonderful introduction. Thank you, Adam. I'll go ahead and share my screen. Okay. So good morning, everybody. Thank you so much for having me today. Today, as Adam mentioned, we were going to go ahead and speak a little bit about the elderly, blind, and disabled Medicaid programs, two sub-programs specifically. But first, I'll give a quick refresher on EBD, and then we'll dive into the Medicaid Purchase Plan, along with the Medicaid Savings Program, and I'll also share a few helpful resources for you all as well. So I just want to go ahead and say that, as many of you know, folks can go ahead and apply for benefits 4 different ways. They can either apply via access.wisconsin.gov. They can go into their local agency and apply in person. They can certainly submit an application through their postal office, and they can also complete a telephone interview with a worker. Here are a few links to the different application forms. Those who are 65 and older and have been determined blind and or determined disabled by the Disability Determination Bureau, also known as DDB, may complete a paper application. They may also complete the application online. The authorization to disclose information to DDB form must be sent to the DDB. And along with that, you should also submit the Medicaid disability application form. If someone is already non-financially eligible for EBD, they may complete and submit the application online. However, let's make sure that they note that they do have a disability or blindness determination. For the purposes of Medicaid, only disability determinations made by the DDB and Social Security Administration make an individual non-financially eligible for Medicaid assistance programs, medical assistance programs. Now, after a person does an application, obviously, we're going to go ahead and ask for verification. And I just want to make sure that all of you know that as you work with clients, please remind them not to skip or ignore verification requests. By doing that, they could cause the request to fail and to be denied. So rather than ignoring them, we should encourage folks to go ahead and comply with the requested verification and work with the IM agencies directly. They should do so if they're having difficulty submitting a type of verification that's being requested. They should also contact the IM agency if they need clarification on what's being requested. And they can also ask for an extension to their due date if need be. Now let's go over some basic non-financial rules. To be eligible for EBD Medicaid, an individual must be elderly, which is 65 or older for Medicaid, or have been determined blind or disabled by the DDB. As a note, some individuals may be eligible for what is called presumptive disability determination. However, we're going to talk a little bit more about that in just a bit. They must also be a Wisconsin resident, and they must also be a citizen or qualifying immigrant. Additionally, individuals must provide a Social Security number with a few exceptions. They also must supply the required information and verification within the required timeframes, hence me mentioning earlier that if they need an extension to their due date, they should contact the agency. And they must pay premiums or cost sharing if required by the specific program. Now, presumptive eligibility is a method of temporary determining a disability for a person while a formal disability determination is being done by the DDB. Presumptive disability is determined either by the DDB or in some circumstances by the local IM agency. The regular disability process must still be completed for a person with presumptive disability. A presumptive disability decision stands until the DDB makes their final disability determination. Now keep in mind, the Social Security Administration does not accept the county's determination, but the county will accept the Social Security Administration's decision. As a note, if an individual is determined presumptive disabled, but then the DDB finds them then if the DDB does not find them disabled, they will lose their disability status and possibly their Medicaid coverage if they're not eligible for any other program. But it's important to note that if a member is not determined disabled by the DDB, and we did have a presumptive disability determination for them on file, the member is not required to go ahead and pay back any Medicaid payments that are made on their behalf while they were determined with presumptive disability. And that's a little tricky, but just know that if we find them through the agency with presumptive disability, but SSA says, nope, they're not required to pay back that Medicaid service that they received. Now for some basic financial rules, most EBD Medicaid subprograms have income limits and asset limits, but these do vary by program. Income limits for some EBD programs are based on the federal poverty level, the FPL, while others are based on the SSI federal benefit rate. All limits are federally determined and mostly are adjusted, usually increased though annually. Current FPL amounts for EBD Medicaid can be found in the link shown on your slide. Now, for the sake of time, I will not be reviewing this entire list, but as you can see here on slide 11, these are some countable incomes for EBD Medicaid, but they're obviously not limited to this specific list on your screen here. And here is a list of the countable assets for the EBD Medicaid that are included, however, not limited to these as well. Note, most subprograms count the income and assets of the members and their spouses. Deductions for EBD Medicaid, there are some allowable deductions, but those too vary by program. But all EBD Medicaid programs allow a $20 standard deduction, as well as a $65 and one and a half earned income deduction. The $65 and 1.5 income deduction is calculated by first deducting $65 of the household's total income, then deducting half of the remaining earned income. There are some subprogram specific deductions as well. So depending on the program being determined, some examples of those subprogram specific deductions include support payments and medical or remedial expenses. This slide here has the links to the Medicaid webpage, the Medicaid Eligibility Handbook, which if you listen to Nikki's presentation on Friday, she likes to call it the MEH handbook. And also I have a link to the fact sheets and to the DHS forms library. So now I just want to show some numbers that we have for EBD enrollment in the month of July 2025. As you can see here, there are several types of subprograms under EBD. And what we'll do now is we're going to shift to some programs that have higher income and asset thresholds for folks to apply for benefits. Now we're going to talk about MAP Purchase Plan. It is a Medicaid subprogram with full benefit Medicaid, and eligibility for MAP is determined by the IM agencies. MAP is for individuals with a disability who are either working or are enrolled in the Health and Employment Counseling Program, which we call HEC. MAP also allows people to qualify as disabled even if they are engaged in a substantial gainful activity, which means that they're earning above a certain threshold. This is different from the Social Security Administration, which generally will not find someone to qualify as disabled if they're working over SGA at the time of their application. The program has a higher income asset limits to allow members to get healthcare coverage while they're employed. MAP information, including information on HEC, can be found in Chapter 26 of the Medicaid and the MEH handbook. The income limit for MAP is 250% of the FPL. And it is based on households that include the member's spouse, and the member's minor dependent children. Meaning if that household contains stepchildren, they're not going to be included in that household size. The member and their spouse's net income is compared to the income limit for the household size. So if a person's household size was 3, his and his spouse's income will be compared to the income limit for the household size of 3. MAP also allows a $20 deduction and 65.5 earned income deduction that we talked about earlier. It allows an impairment relative work expense deduction, a special exemption deduction, exempt income deduction, and a medical and remedial expense deduction if an applicant and spouse have medical and immediate expenses that are more than $500 a month. Premiums for MAP are charged based on the member's income only. If a member's gross income exceeds 100% of the FPL for the group of 1, currently that's about $1,304.17, then the premium will be charged. Finally, the asset limit for MAP is $1,500, and only the member's assets could be counted. So household size include the member, their spouse, and minor children of the member only, excluding those stepchildren. Net income includes the member and their spouse's income and allowable deductions. Premiums are charged based on only the member's income, and only the member's assets are counted. Now we're going to talk about MAP work requirements. That is when they engage in a work activity at least once per month, and it includes receiving wages from an employer through self-employment or training, in-kind work for goods and services. In-kind work means the individual provided a service for someone to return for something of value, which is food, goods or services. Be mindful when you're working with your clients and they're reporting in-kind work. Stay away from words like volunteering. That does not meet the requirement for this particular work requirement. Volunteering means that you're doing something out of your own good and you're not receiving in trade. So definitely we need to report trading in-kind work for goods and services. They also can enroll into the Health and Employment Counseling pre-employment program. This program is for individuals who are not currently employed, but who are looking for work. Members temporarily unable to work or participate in the HEC program due to mental or physical illness, even hospitalization, can apply for temporary work exemption by filling out the Medicaid Purchase Plan Work Requirement Exemption form. Members must continue to pay all applicable premiums during the work requirement exemption period up to 6 months. I should note To obtain the temporary work exemption, they must have been enrolled in MAP up to 6 months first before being eligible. If a member is unable to pay the premium due to a difficult situation, they may be able to stop paying for a short time. This is called temporary waiver. Things to know about the temporary waivers: members may ask for a temporary waiver that can last up to 12 months. Member can ask for a waiver to be backdated up to 3 months. Members may also ask for more than one temporary waiver as long as it doesn't exceed more than 12 months for the same difficult situation. Examples of difficult situation include unexpected expenses related to work, or an unexpected expense that may take a few months to pay off, or not being able to find childcare. To request this, they can complete and request the link here is to the temporary waiver for your MAP because of a difficult situation form. Here on this particular slide, I put a screenshot of the MAP webpage. It has a ton of information, frequently asked questions that I think will be helpful for you to take. I also have here a screenshot of the MAP fact sheets and a link where you can find that on the web. Another one, how to pay your premium. And I think I will be allowing you all to go ahead and conduct this poll. Adam, do you know if we can launch that poll for folks?
Yep, Mike should be able to pull that up right now.
So I'll just read the question. The temporary waiver for MAP premium. Oh, there it is. I can see it now. The temporary waiver for MAP premium payments can last up to A, 3 months, B, 6 months, C, 12 months, or D, 24 months. And Mike, I'll let you cue me when you plan on closing it down.
Yeah, absolutely. We'll give that just about a minute here, and then we'll go ahead and close that out.
Thank you.
All right, we'll give that just another 10 seconds or so before we close that.
Okay, good. I'm very happy to see that. So the correct answer, obviously, if I'm happy about it, it is 12 months. So thank you all for participating in that. So now I'm going to go ahead and talk about the Medicaid Savings Program. Now, let's just be clear that Medicare is not Medicaid. Medicare is a health insurance program that's run by the federal government that has 5 parts. So that is A, B, BID, C, and D. IM agencies, we should know, do not determine eligibility for Medicare. So this came up a question during the session with Nikki on Friday. When you have questions with anything that has to deal with insurance from the federal government, you should be working with Social Security Administration. The local IM agency will not be able to help you. So that's just a quick note there. Now, the Medicaid savings programs are Medicaid programs, but they are limited benefit Medicaid programs. They're not full benefit ones. They help individuals who are enrolled in Medicare by paying the Medicare premiums, and in some cases, their Medicare deductibles, copays, and co-insurances. And again, IM agencies do not determine those programs. Oh, excuse me. And sorry, those programs are determined by the local IM agency for the Medicare Savings Program. You may hear these programs referred to as MSP. Sometimes they're referred to as Medicare Premium Assistance, and and I also have heard of them as called as buy-ins. The Medicaid savings programs asset limits are tied to the consumer's price index that are updated annually. For these, there are 4 types of Medicare savings programs, and the first is Qualified Medicare Beneficiary, which is called QMB. To be eligible for QMB, the individual must be entitled to Medicare Part A or Part B ID. The income limit is 100% of the FPL for a group size of 1 or 2, and the asset limit is $9,660 for a single individual and for a little over $1,400 for the married couple. Sorry, $14,000 for a married couple. If someone is eligible for QMB, which they'll go ahead and they'll pay for their Part A, Medicare Part A, although most people don't have premium for Part A. They'll also pay for the Part B and the Part B ID premiums and their Medicare deductibles, copays, and coinsurances. Also, QMB is the only Medicare savings program where a member will get a forward health card if they're eligible to use to pay for their Medicare deductibles, copay, and coinsurances. This can sometimes confuse the members. They think that because they have the forward health card, they're eligible for the full benefit Medicaid, but this is not true for them, not when they have QMB. So you should make note of that. Now, some members are automatically eligible for QMB. People eligible to receive SSI automatically receive QMB benefits as part of their SSI Medicaid benefit package. So people receiving SSI, remember, are automatically eligible for Medicaid, so they do not need to submit an application to the IM for their Medicaid. And they're also automatically eligible for QMB, so they don't need to submit an application for the IM for Medicare Savings Program either. Now, some Medicaid members who once received SSI but no longer do are automatically enrolled for QMB, including the 503 assistance groups, disabled adult children, also known as DAC, assistant groups. And then both of these are special status Medicaid, and you can find more about them in the Medicaid handbook on Chapter 25. Now, as a reminder, only those eligible for special status DAC Medicaid are automatically eligible for QMB. Some individuals receiving DAC Title II payments, but other income makes them ineligible for the special status DAC Medicaid. If they're not eligible for DAC Medicaid, they are not automatically qualified for QMB. I know we're getting in the weeds here, but bear with me. The next savings program is the specific low-income Medicare beneficiary, also known as SLIMB. In order to be eligible, an individual must be entitled to Medicare Part A and Part B ID. Their income is 120% of the FPL for group size of 1 or 2, and the asset limit is it's $9,660 for single, $14,470 for married couple. If someone is eligible for SLIMB, SLIMB Medicaid will pay for the Medicare Part B and the SLIMB premiums only. The next one is Medicare Savings Program, the specialized low-income Medicare Beneficiary Plus, which is known as SLIMB Plus. In order to be eligible, they got to be entitled for Medicare Part A, Part B, D, income of 135% of the FPL, and asset limit is $9,666 for single, $14,470 for married couple, and they may be enrolled in another Medicaid program, full or limited. If someone is eligible for Slim B Plus, Medicaid will also pay for their Part B, Part BD, BID, Medicaid's just like Slim B. The difference between the two, Slim B and Slim B Plus, is Slim B Plus has a higher income on an individual eligible for any other, has a higher income limit, and the individual is eligible for any other form of Medicaid, cannot have Slim B Plus. They must choose one or the other if they are eligible for both. The final Medicare Savings Program is a qualified disabled and working individual, also known as QDWI. For these folks, they are age 65 and disabled. The individual may have lost a premium-free Medicare Part A as a result of returning to work. The member cannot be eligible for any other Medicaid. Income limit is 200% of the FPL. Asset limits $4,000 for single, $6,000 for married couple. If someone is eligible for QDWI, Medicaid will go ahead and pay their Medicare Part A premiums. Oops, sorry about that. I know that I'm pressed for time here, so I'm going to go rather quickly. A couple of call outs here regarding the Medicare Savings Program, Medicare Savings Programs. People who apply for healthcare benefits, meaning Medicaid, are screened for Medicare Savings Plan. You cannot apply for Medicare Savings Plan individually. Rather, you just apply for Medicaid, and IM will check all programs. People with Medicaid and/or Medicare Savings Plan are automatically enrolled in Medicare Low Income Subsidies LSI program, also known as Extra Help, which assists with Medicare drug cost. Another thing to keep in mind is that many members don't have the name recognition of these programs or even know that they're enrolled in them. Estimate about 60% of people eligible for Medicare Savings programs aren't enrolled. It's important to screen and educate people about this program. And we have here a link that lists estimated numbers of unenrolled people by state and by zip code. Here is a screenshot of the fact sheet on the Medicare Savings Program. I also have the link. And I wanted to go ahead and talk about some additional resources here. One of them is definitely letting you know that folks can get help from others when applying for benefits. Some of these folks are the authorized representatives, conservators, food share alternative payees, food share authorized buyers, legal guardians, and powers of an attorney. These are some of the individuals that can go ahead, fill out forms, and get permission to represent others. But the one that I wanted to highlight here, particularly in this session, is the authorized representative. This is one of the common ones that I see, and one of them that I want to make sure that all of you are aware of the legal tie that you would have with this particular form. I would encourage our CACs, navigators, and assisters to allow folks who want to remain tied to the life of the case to fill out these forms. The level of commitment that our CACs and navigators and assisters have it's very different from the relationship that someone like, say, for instance, if my sister decided to become my authorized representative, she would have more intimate knowledge about my household circumstances. She would be able to go ahead and speak on my behalf. But I wanted to just make sure that you are aware that it's more of a commitment legally, and also a commitment to a member when you become an authorized rep. It's not just for the beginning stages of getting someone registered or apply for benefits. It would last for the life of the case, and you're legally binded to that case. And one other aspect that I wanted to go ahead and highlight here is that when an authorized representative form is being signed, the individual that they're seeking to help and manage their case for them needs to give valid consent to go ahead and to be able to sign that particular form, and making sure that they're aware that they're handing over some authorization over to that individual who wants to represent them, whether it be an individual, whether it be an organization. So just wanted to call that out. And then here we have more information on the different folks who help people enroll in for benefits, apply for benefits and such. And the website is there on this slide for you. And then some other resources that I wanted to highlight is the guide to applying. That definitely has a ton of information. I love the fact that it has the helpful tips, giving proof, the letters that they'll get, things of that nature that could be extremely helpful for the newbies when they're applying for Medicaid. I also have a link here to the policy manuals, the handbooks, forms, and directories. They can go ahead and be located here. I think those are good resources for you all to have. And then more importantly, if any of you have any questions, you can go ahead and reach out to the DHS Forward Health Partner inbox that I monitor along with another colleague of mine, and happy to take your questions for that. So with that, I think what I'll do is I'll go ahead and stop sharing and pivot back over to Adam. Hopefully I didn't take up too much time, Adam. Sorry about that.
I think you did great. Thanks, Masiel. And I should say it probably many have noticed. Masiel actually brought some great basically policy ninjas who've been silently answering all the great questions that we've gotten in the chat with some very detailed answers. So that basically made me obsolete here, but I really appreciate the level of detail, including citations that some of these answers have had. So shout out to Sarah and Brooke for helping. But yeah, Masiel, you did great, and thanks for pointing out the distinction on authorized reps. That question comes up a lot, and I know it's very tempting for assisters to want to jump into that role and help, but there is a higher level of responsibility. But with that, I will turn it over to Masiel Grochocinski for part 2, who, when we can't remember all of the detail about these programs, can tell us who is going to help us out. Thanks, Masiel.
Thanks so much, Adam. Before I get going, there is one question in the Q&A that we wanted Masiel's input on. It's, does a person who gets SSI need to renew QMB, Qualified Medicare Beneficiary? If yes, what are the steps they need to take to reapply? Can you speak to that, Masiel?
For that question, I'm going to call in phone a friend. So I'm wondering if Brooke or Sarah have that, and if not, I'd be happy to take that back.
Yeah, I'm in the process of clarifying that question, and I will add it to the chat in just a few minutes.
Excellent. Thank you, Sarah.
Yep. Thank you. Thanks so much. Okay, then I will get started. Hello, everyone. I am Masiel Grochocinski, pronouns she and her. I am so excited to be here with you today. Very grateful to be invited to speak at this great conference. So I'll be giving a high-level overview of Wisconsin's Aging and Disability Resource Centers, or ADRCs, and our State Health Insurance Assistance Program. And these programs can be really helpful to you to refer people to when they need help with things other than health insurance. As we know, our people come and sometimes they know exactly what they need, and other times they don't even know where to start, understandably. And sometimes they have a lot of things going on, and there's, we kind of want this holistic bird's eye view to help them out. And that's where ADRCs come in. So I try not to speak in acronyms, but these two terms are known better by the acronym than the actual name. So I'll be using the acronyms ADRC, which stands for Aging and Disability Resource Center, and SHIP, which stands for the State Health Insurance Assistance Program. Okay. So picking us off, let's look at ADRCs. ADRCs are part of Wisconsin's Aging and Disability Resource Network. They are the core of the network at the local level. They're the one-stop shop for people. The larger network includes at the state level the Bureau of Aging and Disability Resources, which is where I work, Also at the statewide level, we have our statewide Medicare helpline, which is called the Medigap helpline. At the regional level, we have Aging and Disability, Area Agency on Aging, or AAAs, say that 10 times fast. And then at the local level, as I said, we have ADRCs, and we also have county and tribal nation aging offices, which are called aging units. And you might find some Medicare SHIP volunteers at other agencies at the local level, such as clinics or senior centers. Okay. Now that we have that kind of context, who do ADRCs help? They help basically people who have a disability or who are older adults, which is 60 years or older. We also serve people who are supporting those with disabilities who are older. That could be families, friends, caregivers, advocates, anyone else that they authorize to help them out. And we do serve people who have mental health conditions or substance use conditions, but note that we don't provide services to help with those conditions. So we would help with, as I'll talk about, the other core services that they might need, but we don't give mental health counseling or substance use counseling. As I said, ADRCs are meant to be a one-stop shop. They're Wisconsin's no wrong door system, which means that we will meet people where they're at. That might mean literally meeting them at their home if that's what they need. We will help people over the phone or virtually. A lot of our work is in person at the office. And of course, we will email and mail folks correspondence as well. And before I move on, I just want to point out that that in-person piece can be really critical for folks who are, have a more complex situation. They've got paperwork they need to go over, bring in, or they just don't have that access to technology. And the majority of our low-income older adults don't have access to the internet or smartphones. So that can be a really helpful referral if you're working with people who need that in-person level of help. Okay, once they find us and once we're in contact, what do? We provide information and assistance on all parts of life related to aging or living with a disability. Often people come to us when they are dealing with a crisis or they're going through a transition. Maybe mom's dementia has gotten worse and she needs new supports. What do we get? Where do we start? That's where the ADRC can come in. We help people understand their options and then access those options. Our tagline is your bridge to support. And we provide free, accurate, and critically unbiased information. So we don't get paid by any companies. We are funded by grant and state dollars. And that free and accurate information comes free of charge. The core services, which means all ADRCs provide these services, include information and assistance about aging and disability resources, long-term care options counseling, which I'll get into a little bit more detail, long-term care programs, which I'll get into in more detail, dementia services and supports, benefits counseling, that's my area, transitional services for youth with disabilities who are legally becoming adults, turning 18, adult protective services, and advocacy always. We are always advocates. Some ADRCs may also provide health promotion and prevention services and programs, or have a community health worker.
Hey, Masiel, let's knock out that
Yeah.
poll question while we're at it. Just get that out of the way.
Yeah.
Mike, can you pull that
sure.
up?
Yeah, thank you.
No problem.
All right, so the poll is, Aging and Disability Resource Centers serve which of the following populations? A, adults with intellectual or physical disabilities starting at age 17 years and 16 months. B, adults 60 years and older. C, adults with mental health conditions. D, adults with alcohol or drug abuse conditions. E, families, friends, caregivers, advocates, and others on behalf of eligible individuals, or F, all of the above. And Adam, I can't see the progress, so I will leave it to you to close the poll whenever you deem appropriate.
No problem. I can't either, but Mike can, and he'll definitely do it in time for us.
Yep, no problem. We'll have just another probably 10 seconds on that poll, and then we'll close that out.
Great, thank you.
All right, round of applause. Over 90% of folks got it right. The answer is F, all of the above. Thanks, Adam. Sorry, I blew right past that. Okay, so now that we reviewed who we serve, let's get a little bit more in depth into what ADRCs can do for someone. A core service is information and assistance, which is exactly what it sounds like, helping people understand what is available to them, how they can get it, and empower them to make the decision about what benefit programs and services best meet their needs and accomplish their goals. I mentioned before that a lot of people come to us when they're in a moment of transition. They need a higher level of care. They need to understand what they can get and then make a decision. That's where options counseling comes in. That is supported support throughout that entire process of figuring out what somebody can get in terms of long-term services and supports, and then helping them make a decision that, again, best meets their needs and their goals, and then supporting them through the application process and actually getting that service. ADRCs are actually the only point of entry for publicly funded long-term care programs. To get a publicly funded long-term care program, you have to be financially eligible and need a nursing home level of care. There's a few different options that people can choose from, including family care, which is home and community-based services for long-term care, family care partnership, which bundles Medicare, Medicaid, and those long-term services and supports, and a program called IRIS, which means include, respect, I self-direct. So ADRCs can help people access those. ADRCs and county and tribal aging units also have benefit specialists. Benefit specialists help people understand, get, and maintain health insurance, income programs, housing programs that help them with costs for living, and can refer them to legal aid. Benefit specialists are an excellent resource. They're advanced advocates who can help with high-level complex situations, including appeals. And they, I think, uniquely have that holistic bird's eye view of somebody's benefit program. So, you know, most places are specialists, right? Social Security can help with Social Security. Medicaid can help with Medicaid. Medicare can help with Medicare. Benefit specialists can help with all of it. So they can speak to how a change can, you know, have that domino effect and affect other programs. And they can help people have that, that kind of coordination of benefits. We have a few different types of benefit specialists. Some will get referred to the appropriate one. Disability benefit specialists help with, you guessed it, disability benefits. Elder benefit specialists help people age 60 plus. Tribal benefit specialists specialize in unique tribal programs, so they can help with everything. Then they have that specialization for tribal members. And we are also lucky enough to have a deaf disability benefit specialist in the Office for the Deaf and Hard of Hearing who can help anyone who speaks American Sign Language. And I will pause for questions. I saw one question is about a referral. I will get to that, but go ahead, Adam.
No, they're great questions that have come in. There was a question asked last week during pre-licensing, I'm guessing, if CACs, community health workers, and other clinic staff can help with Medicare enrollment, or should they just refer patients directly to the ADRC? And that kind of ties into, can the ADRC help with simple Medicare enrollment or only complex cases where they work with an elderly benefit specialist?
Yeah, that's a great question. I'll be getting more into Medicare counseling, but ADRCs can and do help with basic Medicare enrollment. I'll put at the end of my slides our link to finding your ADRC. I think it's always a good practice to reach out to the ADRCs and SHIPs in your area and find out what their practice is, because We do all help with it, but depending on caseload and setup, some might have a different kind of triage system. So you can learn what theirs is in your area.
All right, and then since time is going to become a factor, let's just do one more for now, which is, can the ADRC help with Social Security disability determination, like guiding somebody through it, or is it just for those after they already have the determination?
Yeah, thanks for this question. Disability benefit specialists, like, main role is helping people applying for Social Security disability benefits. So they do help get disability benefits, Social Security disability benefits, including SSDI and SSI, not just after someone's got the determination. Thank you. And we will keep going and pause for more questions. Okay, so a little bit more detailed about Medicare and Medicaid assistance. The State Health Insurance Assistance Program is a national grant-funded program that provides unbiased and free Medicare counseling. All benefit specialists and ADRCs are SHIP counselors. Not all SHIP counselors are benefit specialists. So SHIP is kind of a broader umbrella term, and our core workforce are benefit specialists at ADRCs. ADRCs help people apply for Medicaid, and SHIP helps people with Medicare. So once again, we're kind of, I think, uniquely situated to help people who are duly eligible get those programs and then navigate their coverage choices. We help with almost all enrollment for Medicare, just a couple of exceptions. While we can help someone enroll in Medicare for the very first time, we generally refer to Social Security just because it's more efficient. Although because Social Security is so backlogged now, I wouldn't be surprised if that changes a bit. We also help people pick what Medigap or Medicare supplement policy they want, but don't actually do the phone call with them to enroll. So a little bit more detailed, again, we help with eligibility and enrollment for Medicare. Plan comparison is big, and then we can provide that higher level assistance, such as coordination and coverage issues, appeals, and then counseling for those programs that help with costs, such as Extra Help, the Medicare Savings Program and Medicaid that Masiel talked about, and Senior Care, which is a drug coverage program. And we advocate for systemic improvements as well. As I mentioned, we don't help that one-on-one enrollment, the actual enrollment with Medigap. We refer out for marketplace enrollment, and then we can't have any conflicts of interest. So an example of that is working with agents. We have to be intentional if we're ever referring to a particular plan or agent, or if we're referring to our plans or agent, it has to be everyone available in the area, not just a particular one, so that we remain unbiased. And just reiterating, we are kind of well positioned to help people who are duly eligible for Medicare and Medicaid. They have a lot of different options in Wisconsin. Understandably, it's a lot to understand and navigate, and our benefit specialists are great resources for that. I was getting some questions about spend down from other coordinators. So just FYI, we can provide high level information about spending down assets to qualify for Medicaid, but any individual counseling someone wants would be referred to an attorney. Okay. Checking in on questions. If someone is already on Medicaid, turning 65, should they still enroll in Part C and D? That's a great question. So if someone has Medicaid and is getting Medicare, they're becoming duly eligible. They'll actually be, if they're going to be reassessed for elderly, blind, and disabled Medicaid if they were on Badger Care Plus. And in that case, they would be automatically enrolled in Extra Help and therefore a Part D plan. But if not, I guess the short answer is yes, they should enroll in drug coverage. That can either be through a Part C Medicare Advantage plan or a Part D drug plan. So that's my short answer. Yes, they should get drug coverage through one of those options. Okay, I'm going to keep going to answer the one question. You can refer to an ADRC anytime someone needs help with anything I listed in the core services. Again, when someone's going through a transition, they need resources, or they just don't know where to start. For other referrals or for referring elsewhere, I'd say if somebody has a very specific need and you know what it is, like they need to apply for LIHEAP, it might just be more efficient to send them straight to the source of those who can make the eligibility determination. As I said, we don't provide mental health services. And if that person has a case manager elsewhere, it's more efficient for us to have that case manager do whatever they can, and then the ADRC steps in to fill in the gaps. We want, we're always triaging because there's so much demand. So we want to make sure that those who don't have any supports get help from the ADRC. So if they have a case manager, check in with them first. As I said before, talk to your local ADRC to find out their preferences for a quote good referral. But generally, it's helpful to spell out what action you want the ADRC to do, who's most appropriate to contact, and highlight any deadline or timeline considerations to help them with that triage process. And FYI, the ADRC has to talk to the client, the person who'd be getting services, to proceed. So doing a three-way call or just having that person call the ADRC would also be most efficient. And you have the slides. Here's the link to find your ADRC and also a link to a map. We also now have a statewide phone number to get referred to your ADRC. So very excited about that. Please share that. You can find SHIP information at this email, at this URL. That includes finding benefit specialists at ADRCs, our helpline numbers, and other places you can get SHIP counseling. Also, an FYI, if you want to do a deeper dive into Medicare, we offer free webinars highlighting Medicare updates prior to the open enrollment period every fall. This year's is October 7th through 9th, and you can email me to get those email updates. Thank you again so much. I went through a lot of information quickly, so please don't hesitate to reach out if you have other questions. And I see we've got a couple in the chat, so I will let you moderate that.
Sure. You did a great job with the time, by the way. Everybody appreciates it for sure. So why doesn't the ADRC not assist families in nursing homes who are in need of caregiver assistance? And maybe you could speak to, I'm not exactly sure about that, but Michelle, I'm assuming you know a little bit more about what they're asking.
Yeah, I'm not totally sure, so feel free to email me if I miss the mark here, but
Okay.
ADRCs help people in the community, not who are in nursing homes. So if someone is transitioning to a nursing home, we can come in, but that's our focus population. So it could be if someone is in a nursing home, that's what's impacting them getting services. But feel free to email me with more specifics because I'm not totally sure I followed.
Yeah, there might be just a policy reason behind that, an age-old one at that. So, but we could certainly look into it more. And if a person's SSI amount went down and they don't know why, would they be able to connect to the ADRC for help? Is that something an ADRC staff person could figure out?
Yes, that's actually a great example of why someone would come to the ADRC. So if someone's supplemental security income, SSI income went down, they don't know why. That's what our benefit specialists are trained at figuring out and then helping correct if something needs correction. Yes, thanks.
All right, great. I don't see any more questions in the Q&A. Some really great ones though for both segments of this this presentation. So I just want to thank everybody for their participation today. A lot of great information this morning. Thank you, Masiel. Thank you, Michelle. Thank you, those DHS policy folks in the background giving those detailed answers. And yeah, more conference to come, more exciting topics to cover. And I will turn it back over to Allison to sing us out. No, not sing, but get us out of here.